Hi, my name is Rick Labuda with Conquer Chiari. I am joined by our afternoon speakers, Dr. Jonathan Millard, who gave a presentation on anatomy, Dr. Allison Ashley-Koch, who gave a presentation on the genetics of Chiari, and Dr. Rafeeque Bhadelia, who gave a presentation on cough-associated headaches, how to assess them. So I'm gonna start with the questions that were asked during the presentations, and we will start with Jonathan. Says, thank you for this detailed anatomical tour. My question is, given Chiari anatomy that you described, do you think that that would impair the brain waste clearance or the lymphatic system? And does a duroplasty or the scar tissue that the dura often has in Chiari patients, can that also impair the lymphatic system?
Yeah, well, thank you for that question. That is a very good question. And I don't know, to be completely honest. I think there's been a lot of interest in recent years about the lymphatic system in the brain. There's been a lot of stuff that's come from the University of Virginia about that, a lot of novel discoveries. So as far as how that could affect the overall, volume problem within the, cranial cavity, that would be an interesting question. I don't know for sure. But
could you just spend a minute kind of describing what that system is in the brain?
Yeah, sure. So we have a lymphatic system all over the body, and that's been described for hundreds of years about how the lymphatic system works. And what the lymphatic system is really, so out in our tissues, whenever the blood gets pumped out, it gets pumped out into smaller and smaller vessels, arteries, arterioles, and it'll enter our tissues. And part of the fluid that's resorbed back, about 10% of the fluid in our bodies in these interstitial spaces, will return back via this lymphatic system. So, if you think about the lymphatics, you can have lymphatic problems in other places that are very well described, right? So there's the swelling and stuff, that's associated with lymphatic disturbance. And they've recently, within the past, few years, certainly relative to other lymphatic discoveries, they have been able to show that the brain itself also has a similar type of system. And that is very new. And like I said, they did a lot of that work at UVA, just down the road from where I'm at. So very cool and very interesting. And as far as getting rid of that brain waste, that is a good question that I don't have an answer for. But I mean, it's thinking about it as a volume problem is certainly within the realm of Chiari malformation concern. So there's probably some interesting research questions in there for sure.
And if that system were impaired, would that lead to some cognitive deficits and cognitive issues?
I would hesitate to speculate too much about that. Perhaps it would be, I don't know how they would go about measuring it or quantifying its disturbance, but okay. I wouldn't be surprised. Yeah.
All right. Thank you. Allison, if a child does not have EDS as shown through genetic testing, but has very poor wound healing, do you think it still might be some type of connective tissue issue related to Chiari?
That is a great question. I mean, first and foremost, EDS, or Ehlers-Danlos syndrome, for those of you not familiar with the abbreviation, there are lots of genes for different types of EDS. And there's even more genes which are involved in connective tissue disorders just generally. So, I think it's certainly a possibility that even if a child doesn't meet the formal EDS diagnosis, there could still be some sort of genetic or some other disturbance in the connective tissue. Yes.
How well described are the genes associated with the hypermobile EDS?
There are a number of them, and I apologize, Rick. I should probably know off the top of my head how many there are, but I would say there's probably about 10 or so that are known specifically for EDS. And even within EDS, there's a lot of what's called clinical heterogeneity. I talked about this a little bit in terms of Chiari malformations, because patients can really present with very different types of symptoms. So just because someone doesn't necessarily exhibit hypermobility doesn't necessarily mean there's no disruption
Right.
to the connective tissue.
Right. Excellent. Okay. Thank you. Dr. Bhadelia, can you clarify what nerves are actually being aggravated or triggered with a cough-associated headache? Rafeeque. You have to unmute. There we go.
So we exactly don't know in terms of how the headache occurs after a cough, but there are two possible mechanisms that could cause it. One of the mechanisms was proposed by Williams when he did a lot of research with brain pressure measurements in 1980s and 70s. And he speculated that there is a transient increase of intracranial pressure associated with cough-associated headache, because after somebody coughs, there is increased pressure, which in normal person dissipates easily because the CSF moves out of the head. But in a Chiari patient, it doesn't happen, and their pressure could go up. And that is what he measured when he was doing his experiments by putting some catheters in the head and in the spine by measuring differential pressure. And he suggested that the headache was caused by irritation of the dura. Now, he didn't explain what part of dura. The other mechanism that we are thinking is that it could also be related to dura, but the dura is related to upper cervical spine. So that would be the first and the second cervical nerves. Those are supplying those dura, and that could be irritated by that. So that is a second mechanism one would, people have proposed, because people say that when you do cough, and when you cough and the tonsils suddenly descend downward, that could straight the dura and can cause pain, or maybe straight the nerves. We exactly don't know, but those are the two mechanisms we have proposed previously in our papers, but exactly we don't know.
Okay, thank you. Okay, back to Jonathan. Do you think it would be possible to identify small posterior fossas externally through skull measurements, especially in kids as they develop and grow?
This is a good question. Yeah, I can't answer directly, but I think it's getting at an important point, which is, can you make predictions about the outcomes, with more and more elegant and more simple, interventions or measurements and things. I think that is something that is, it would be good to shoot for anyway, at least. So, I mean, there's probably a study in there. Absolutely. I will say, I mean, when it comes to measuring the posterior cranial fossa and what they do know about it, a lot of my interest and a lot of where I see, potential for perhaps some improvement is improving on, just simple linear dimensions, like Dr. Loth's presentation showed, a lot of these measurements are coming out of the mid-sagittal plane, which may be as good as we got right now. And that's totally fine. And that's good. But I think there's a lot of possibilities, and there's certainly a lot of shape data that we're sacrificing by only exclusively looking at the clivus, only looking at the clivus in that one dimension. So I think by spreading out into 3 dimensions and looking at the whole clivus, looking at the whole atlas, looking at the whole axis, looking at the whole odontoid, that may shed more light on people's outcomes and may help predict whether or not they're good surgical candidates and help guide clinical decisions. So as far as, could you wrap a tape measure around someone's head and, learn something about their future? I don't know. That's, that I guess that possibility could be there. But that would be an interesting study.
Well, I think it's important, isn't it important to keep in mind that there's so much variation among people, right? in skull shapes, even among people with Chiari. When you look at the skull shapes, if you go through 10, it's like looking at 10 just completely different images, and some you have herniation and some you don't. So I don't know. Personally, I'm a little skeptical that would be possible, but maybe it would be. All right, thank you. Allison, can you clarify whether there are family clusters that are not EDS connective tissue related? In other words, if someone has the more classic Chiari with small posterior fossa, do you think it is then possible they can pass it on to their children?
Yeah, that's a great question. We actually think both forms are genetic, or at least a portion of both forms are genetic. So whether you're connective tissue disorder positive or negative, we believe that there's probably some genetics underlying that. The challenge is what we think currently is that there's different genes that underlie the connective tissue disorder positive versus the connective tissue disorder negative. And even if you were to look within connective tissue disorder negative, in my family, it might be one gene. And for example, in Rick's family, it might be a different gene. So that just sort of shows you how complicated genetics of Chiari really is.
Okay, thank you. All right, Dr. Bhadelia, for a typical Chiari headache, does the flow of CSF have to be restricted both in front of and behind the tonsils, or is the posterior or the backside of the tonsils enough?
So I would say from my clinical point of view, what I'm saying that whenever you get the tonsillar herniation, it goes down, or we can say tonsillar descent, it goes down into upper cervical spine. The CSF is always restricted behind the cervicomedullary junction. It is always the anterior part which is more important because it comes later. As the descent is more, the brainstem is pushed forward. I would say that as the herniation descends further, slowly the anterior CSF space gets narrower, and that's where the symptom starts coming. So getting only the posterior CSFs restricted is not enough to get pain if there is open channel anteriorly. I hope
you get an award for a direct answer, Dr. Bhadelia.
No, I think this is years of observation. I know there have been a lot of publications about posterior CSF restriction, but I think we recognize it very early that it happens very, very early on in the Chiari malformation. And as you pointed out in the beginning, where we're discussing that the anterior CSF space is kind of correlates more with symptoms than the posterior CSF space.
And that leads to my next question to Jonathan. There were some talks this morning that some research talks which showed the importance of that anterior CSF space and that it might actually reduce with age. Anatomically, what might be happening other than herniation that can cause that space to get smaller? Any thoughts?
Yeah, that's a good question. I mean, so kind of like with all anatomy, there's going to be variability in all of these spaces, and there's not a lot of room for error here. There's just a normal, you could have a broad amount of anatomical variability from a wide number of things that determines you or my CSF spaces anyway, and that may or may not be problematic. It could be mesodermal in origin, coming from the bones, the way they're shaped. It could be them plus, the ectoderm, maybe just something about the nervous system itself is shaped weird. Maybe both of those need to happen. And then, as far as age-related changes, your spine does change a lot as you age. Just earlier today, I had my hands on a donor in the lab, and I see a lot of bony changes and bony growths in the osteophytes and things like this. So there's also a lot of disc degeneration that happens with age, so you lose a lot of height. And there are other things like pseudotumors that can grow around the odontoid and stuff that's related to cervical.
So what about subtle cervical instability? If Chiari patients have some instability that is not identified clinically because it's not necessarily severe, but over time can that kind of degrade things, and often Chiari involves, you know, cranial settling as well. Can those types of things come into play?
Well, if they're not fitting together right, I mean, just from an anatomical standpoint, if they're not fitting together right, then the shape of the dura and then the arachnoid, which is applied directly against it, would be, they would have to would necessarily be affected by those changes, you know. So I mean, it's not inconceivable that it could change the shape of the subarachnoid space and, you know, the CSF space. As far, I'm not familiar with any studies that, you know, that are probing at that specifically, but I would just say there's a lot of things that have to come together that will determine your CSF shape over time, for sure. And that could be ligamentous, like in the case that Dr. Koch is looking at. It could be connective tissues, it could be bones, and it could be the ectoderm itself. So,
thank you. All right, back to Allison. Some people speculate that Chiari symptoms may involve an inflammatory response. Are there known genes that make people more likely to have a more pronounced inflammatory response?
That's a fantastic question. So the short answer is yes, there are lots of genes that influence our inflammatory response. They have not, unfortunately, been looked at directly in Chiari, at least to my knowledge, but you know, you can think of, there are a number of autoimmune disorders that are out there that we have some genes for, such as rheumatoid arthritis, multiple sclerosis, and so forth. And so we do know that genes do play an important role, you know, in our inflammatory responses. You know, and interestingly, I mean, if you think about rheumatoid arthritis in particular, you know, this is an inflammatory response that really impacts joints and connective tissue.
right.
And so I think that's actually a really fascinating theory. So something to be examined.
I would just like to build on that and say that the data from Chiari-1000 has shown high prevalence of Raynaud's syndrome, even without associated syrinxes, and also very high levels of autoimmune diseases that have very specific tests, such as lupus, not just the more general ones like chronic fatigue or fibromyalgia. So, you know, maybe that inflammatory genes, the collagen genes, you know, maybe there is something going on there. All right, Dr. Bhadelia, we got a question here. Do herniations continue to get larger, or do they reach a certain point and just stop there?
You know, to be honest, with my personal experience, I think I've read some articles where say that herniation kind of increases from childhood and then reaches to certain points. But my experience is that when I have seen them, they're already, people are usually symptomatic. Whenever I see them, they've reached to their maximum and they didn't change much. The only thing I saw them changing is different people measuring them differently. You know, that would, you know, if I measure it like 11 millimeter and somebody else might measure it 15 millimeter.
Right, and that speaks to the difficulty of doing that consistently, right?
So if you follow the exact rules of what are supposed to be, and the problem is not everybody is expert in measurements of Chiari, and a general neuroradiologist or a radiologist in community is measuring, may measure it very differently. The other thing that we notice, and as Mr. Labuda, Dr. Labuda is aware of it, is that we publish that sometimes people don't measure exactly in the midline, but they measure it offline. And one of the cerebellar tonsils may be further down than the other. Now, you need to have both tonsils to a certain degree down before people get symptomatic, because if one tonsil is not herniated at all and the other one is herniated even 11 millimeter, it doesn't matter because CSF has space to get around from head to the spine, and there would be not much of a symptom or maybe no relief after surgery. So that is again another thing. So honestly, I think that they might be increasing over the time period, and that is why we get the first peak in the childhood and the second peak in around third or fourth decade of life, like 30 or 40 years of age, 30 years of age, when we see again another symptomatic peak. There has to be a time where it might be increasing and reaching to a so theoretically, yes, I believe that. I think there are a couple of papers like that. I've been looking for them and I haven't been able to figure them out again. I thought I read them many, many years ago, like in the 90s, but I haven't read them again. But I think that's a good question.
Okay, great. We're going to go back to Allison. We're getting some questions in through the feature on the call here. Is Noonan syndrome something that is associated with Chiari?
That's a great question. So Noonan syndrome typically is associated with kind of a larger head rather than maybe a smaller compressed head. Having said that, you know, I did talk about in my presentation, you know, that one of the studies that our group participated in did find a couple of genes that were particularly associated in pediatric onset Chiari, and those patients with those genes actually had a larger head rather than kind of the more compressed. So, you know, it's entirely possible that, you know, that there are similar symptoms that result, but it's really just kind of a different variant and a different gene that's causing it.
Okay, thank you. Let me see if we have any others here. Dr. Bhadelia, are there any exercises or movements of the head that can help promote the flow of CSF if someone has known restriction at the craniovertebral junction?
So if there is no restriction.
No, known. In other words, you know you have restriction there. Is there
restriction.
something you can do? Yeah.
I guess generally, what again, we go back to the anterior cervical space gets wider when you extend the head versus when you flex the head. Because when you flex the head, the craniocervical instability usually gets worse with the flexion. And whatever especially if you're thinking about movement in the atlanto-odontoid joint or basilar invagination, where the odontoid process goes up, it gets worse with the flexion. But I don't know, honestly, if there is any exercise that would help, but flexion generally makes the space worsen. So that is why I think.
And which is flexion, the back or the forward?
Flexion is in forward movement, yes.
Flexion is going forward, okay.
Yeah, flexion going forward would actually move the odontoid process a little backward and narrows the space. And that is why the discussion about how the interior space gets reduced can be another factor, maybe instability of the craniocervical junction, or maybe deformity of the brain skull base or basilar invagination, where the bones are high already, and that could actually impinge on the anterior cervical CSF space and can go and hit the the medullary junction. The odontoid process, retroflex odontoid process can do the same thing. Okay,
we're going to stay with you. I'm going to change this question a little bit, but basically they're asking about a recurrence of symptoms after surgery. So I will ask that from a radiological point of view. Are you able to identify scarring? You know, there's been in the literature, it says that most recurrent symptoms, or many, but a lot of recurrent symptoms long-term, 5, 10, 15 years after surgery, are due to the buildup of scarring in the dural tissue. Is that something that can be identified on MRI?
The simple answer is no.
Okay.
I still don't know. Yeah, I still don't.
Well, that is an answer. Do you see in your clinical practice, do you see a lot of people, 10, 15 years, you can tell they've had a surgery a long time ago and now they're back for symptoms?
Well, there are people coming after years, but usually they come more often, a year or two after surgery, and they continue to have symptoms. maybe not.
Right, so it's not that it's, right,
What they present, but again, it has to be a question where I'm not like, I don't have a Chiari clinic, so they would come to me
right,
and I would see
right.
it. So what happens is that I've incidentally seen it, one patient or two patients in over 30 years of time. I wouldn't have remembered that. So yes, I don't know. But what is happening is that I get often 1 or 2 years later requests for a regular CSF phase contrast study for impairment of the CSF flow. The patient may be symptomatic, but the study may be normal. So that is my experience. And we also do high resolution T2 weighted images to try to see or visualize any arachnoid membranes or anything that may suggest arachnoiditis. One potential thing is that many times, one thing I could suggest is, which I don't think anybody has done, is to do a gadolinium enhanced study to see if there is any enhancing membrane like we do it in the lumbar spine. I don't think that has been done, but that is one question.
So that's the injection of a,
Contrast, yes.
yes,
And
this is an injection which
right.
increases
So if there is
the
adhesion,
contrast in the image.
right, contrast maybe in the lumbar spine when there is arachnoiditis or inflammation of the arachnoids. When you inject contrast, it can actually give rise to enhancement of the membrane. And one potential possibility, I don't know, I haven't looked at it, is that would that show if somebody has done that study? I don't know. That potentially might look at, yeah.
Thank you very much. I'd like to thank our presenters for their great presentations and for participating in this panel discussion. We are pretty much out of time. So I think that's going to wrap it up for any attendees listening in. You can go back and view the poster hall. We are done for the presentations for the day, but I encourage you to review all the posters in the poster hall and see all the great projects that Conquer Chiari and our partners are working on. Thank you very much. Have a good evening.
Thank you.
Thank you.